Thanks for coming and for supporting this important work. For those of you who don't know who I am, I'm Miriam Kalamian. As Angela told you, I'm a keto nutritionist and educator. I don't have any institutional affiliations. I don't work in a clinic. I have my own consulting. And there we go. I have done some consulting work for MaxLove and for the Keto Therapeutics Food Company. And I'm very excited to be here today. So thanks for coming. I work with clients, not patients. I make that clear to people. And my work is primarily with people with cancer, and most people that I work with are also undergoing standard therapies. So that certainly complicates the picture. So I have a lot of experience with adapting the ketogenic diet for people with a variety of special needs. One size fits all? Don't think so. Not in practice, not in clinical trials. We tailor the plan. You know, one of the really important things to me is that every person that I work with is totally on board with the changes that they're going to need to make. Early on, I would start to help anybody that contacted me, but I realized that unless that person has made the commitment, we're not going anywhere with it. So, they make the commitment, I will make the plan for them. I will do it. So they need to be on board, or at least willing to try, and not be doing this under the pressure from a spouse or another loved one. So it's a huge step, because there's a lot of anti-cancer diets out there. So people will come to me with, well, how is this different from Budwig? How is this different from Gerson? And so there's a lot of education on the front end on the science behind the diet. So how do we know if somebody is a good candidate? So they've told me they want to do this, but how do I know they're a good candidate? Well, first, there was a consensus statement that was developed 2008, Beth? And it was for epilepsy, but those same contraindications are true for any application of the diet. Thankfully, I don't run across the contraindications very often, the absolute ones, because they're mostly things that are identified in childhood. So, in a perfect world, I would have people willing to, medical teams willing to run the tests and to look at some of these, or just even give me a baseline vitamin D. But in reality, that doesn't happen in my world, and people, even if they get the test, they don't have insurance coverage to take care of that. So I kind of boil it down to one question: have you ever tried the Atkins? And if they tell me yes, we're good to go. So there's some other things I want to know in that initial information. I want to know how they found out about the diet, what they know so far, and what are their expectations. If their expectations are that the diet is going to cure them of their cancer in 2 weeks, we need to talk about that, be more realistic. And I watch out for this very revealing question, and that is, how long do I have to stay on this diet? There they are, friends and family. They can, when they're supportive, it's great, and when they're not, they can undermine commitment and destroy compliance. But these guys, this one right here, I would really love that every person I work with have a medical team behind them, but the reality is it more often looks like this. And this guy right here, he's actually the least harmless one, even though he's got that lollipop in his hand, because he's going to tell my client that diet doesn't matter. And so what I say is, if diet doesn't matter, then he shouldn't mind if you're doing a ketogenic diet. But this guy's a little more of a problem. This was perfect. He has that look. He knows it all. He doesn't want you to waste his time discussing diet. And if you don't go along with the program, there are consequences. There really are consequences, by the way, if you come up against this guy right here. But this one is the one that I have the hardest time with. And there are actually eye rollers out there, intimidators, bullies. There's bullies. And that is unprofessional and inappropriate, and my suggestion is fire that person and move on. This is a good indication right here of what you're going to run into in trying to communicate with your team about anything. So how do we find doctors who are going to be supportive of the diet? I wish I had a really good answer for that, but I don't. And it's a huge problem in my world, and I hope that we can start to make some progress in that. Some of the larger cancer centers at this point are actually not throwing up obstacles. They're seeing the results of many more people coming through, and so they're not supportive, but they're not getting in the way anymore. But for local monitoring, I rely more on GPs. A lot of people have a really good relationship with their general practitioner, and naturopathic doctors. And boy, we really need a system to educate people about the science. And I need to be able to say, oh, you're in St. Louis, then this is who can help. And we don't have that yet. So in building the framework, I'm looking at what we got so far. All right, we have my clients on board. She looks like a good candidate. She's reading up on the diet. She's asking questions. Friends and family have pledged their support, and the medical team is not getting in the way. That's as good as it gets. So this one, boy, this was a hard slide for me to put together because this could be the whole talk, and it could be 3 hours. I'm serious about that. And like I said, I've worked mostly with people with cancer, and this right here, the treatment side effects are, so many of them are GI side effects. It's nausea, vomiting, constipation, diarrhea. So you're making this huge change in your diet, and you're dealing with this at the same time. And I wish I had the time to talk to everyone, answer everyone's questions about how we deal with that, but it's really very individualized. I say get ahead of it though. Get their team involved. If antiemetic, if Zofran is going to help with this, get in there with it. If constipation is a known issue, get ahead of the constipation. Don't wait for these things to happen because they can really undermine what you're doing. Food intolerances and impaired digestion, so common for anyone over 50 actually, but especially for people with cancer. Just to give you one example of a non-cancer one would be the FODMAP. Everybody's heard about FODMAP intolerances. And, and that becomes really, restrictive in terms of an already limited diet if you can't have cruciferous vegetables and avocados and almonds. Gallstones. What people with gallstones, who among them are being told that they should have a high-fat diet? It just doesn't happen. So, if somebody has a history of gallstones, they're kind of afraid to get on board with the diet. And if they've had their gallbladder removed, they may be afraid that they won't be able to digest the fats. And that's just not true. They can and do work with this all the time. I don't let that be an issue at all. Pancreatic enzymes really help get over the initial problems with digestion. And it also helps people get over the anxiety that it isn't going to work for them. Hypothyroid. I've been told that people with hypothyroid should not be on this diet because it's too disruptive to their hormones. And again, that's nonsense. You may see some change in the first month or two in thyroid hormones for somebody that's dropping into a low carbohydrate diet. But we can work around it. There's only been a couple people that I just wasn't able to work with there. The medications do mess with glucose control, and I do keep the carbs higher with somebody coming into it with hypothyroid. I don't want to go down to 12 grams of carb. High cholesterol. Nobody here is really that terrified of high cholesterol, but I hear it, oh, my cholesterol is high and my doctor doesn't want me to do this diet. And if the doctor doesn't want them to do it, and they're thinking this could be a problem, then we got to have a little education session about pattern A, pattern B, about the HDL levels, about triglycerides being more important, and and what is the goal here? Is it to lower your cholesterol, or is it to fight your cancer? bowel disease that manifests in about 1 billion different ways. And that, boy, I would really like it if it's just as simple as changing out a few foods, making some changes in what they're eating in fat, maybe changing the meal timing. And if not, that is sometimes something that people can't get past. And that's unfortunate, but then I still want to help them. And I still want to optimize their diet, it's just not going to be ketogenic. Seizures. People with brain cancer often find out that they have a tumor because they've had a seizure that's landed them in the hospital. There's medication that is most commonly used for people with brain cancer is Keppra. That doesn't seem to create any problems in terms of diet, but occasionally I'm working with somebody who's been put on valproic acid, and that does deplete carnitine, and so they have to get ahead of that. A lot of dealing with these accommodations is just getting ahead of it, knowing enough about what their issues are that you can alert them to this, because their team isn't taking time to talk to them about it. Their team may not even know it. Personal or family history of kidney stones, again, this should not be a reason not to do the diet, and I have struggled with a few people. You got to work real tight with them if they have a personal history. I do like them to consult with their renal specialist, and I do ask that they keep oxalates low, particularly in the first couple of months. Again, it's a little limiting, but it really it helps. And I also am careful about I really want them tested for vitamin D levels. I want to optimize it, but I don't want them taking any more than they need, because that can be an issue with kidney stones. Steroids. A lot of people, not just brain cancer, but a lot of people in cancer treatment are taking either dexamethasone or prednisone, and some of my colleagues think you can't work with that, but I'm persistent, I guess would be the word, and I have worked with that, and and it's a wonderful feeling when you can get somebody through that. I've been working with a fellow who has a glioblastoma, and he had some treatment-related side effects. They had to increase his dex dosage to 24 milligrams. That's an incredibly high amount of dexamethasone. And his numbers shot up. He had good glucose control till that, and then his numbers shot up to like 130, 140. But it worked for him, and so as his symptoms resolved, we stayed on top of bringing the level down, doing it the proper way with a wean. He did not have a rebound. His numbers dropped back down into the 60s and 70s. So you can do that. Opiates. Opiates for pain control. We need this for people with advanced cancers, and it causes some really nasty side effects, primarily slowed GI motility and constipation, and it's a really intractable kind of constipation. And again, you got to get ahead of it. I'm not surprised at how many people actually develop this issue, but I am surprised that nobody has told them when they prescribed the medication or when they picked up the medication that that they need to stay ahead of this and do a lot of proactive things to prevent the constipation and the GI side effects of nausea and vomiting. The other thing about opiates is, and I do warn people about this, especially those who are at home alone, is they can really cloud your thinking and result in falls or overdoses. And I have seen that. I'm not just, I'm coming from a real personal place in that. I've seen it. Barriers to compliance. I wish I could spend hours talking about barriers to compliance. I just kind of let you absorb that while I tell you about a woman that I worked with who had a lot of challenges, and this is how they all come together. So this is what I learned about her. She had recently been diagnosed with a stage 4 cancer and had immediately gone to a ketogenic diet at the urging of her grandson, which was a wonderful thing. She and her husband were both in their 80s and living in their own home. That's kind of an obstacle right there. Considering a move, She had no help with household chores, and her health issues included hypothyroidism and osteoporosis. But on the plus side, this was one sharp lady. She was bright and able to understand the concept behind the diet. Her thinking was clear. She had no digestive problems, even though she didn't have a gallbladder, no issues. She slept well, which for a person in their 80s, for any of us, that's a real plus. And she started the diet with a really good supply of commercially prepared, pre-cooked keto meals. And I can't even begin to tell you how much of a benefit that is for her. She didn't have to think about, she had plenty of time to get up to speed on what were keto-friendly foods, so she could continue to make what she would normally make for her husband, and then have these keto meals for herself. So she emailed me a couple of days into it and told me that she was feeling shaky, tired, and having a hard time on the stairs. And it's like red flags, because those things don't mix with osteoporosis. And she asked if it could be diet related, or was it the 2 days of having to run into town for these doctor's appointments. She called them hectic days. So some of these symptoms could be diet related, but of course she was overwhelmed. Hectic doesn't even begin to describe the chaos you're thrown into with a diagnosis like that. She stuck with the diet for 2 months, but then the barriers to compliance won out. But she's told me that she had benefited, and her scans are looking really good, and her doctor says that happens sometimes. So, as part of the intake, I gather info on food preferences. One size doesn't fit all, so I want to get information here. And as I work through the lists, I'll hear things like, well, I'm not a fan of cauliflower. And I say, well, you're in luck. There's no requirement for cauliflower. And it's true, because I'm going for a range of macronutrients and keto-friendly foods, and they can be combined in any number of ways, and that is the personalization part. People can get some of this from the internet, but I can really help sharpen up what they're doing. So, so if somebody tells me, oh no, they can't do this, canola oil. No, they can't do. It's not like I recommend it, but oh no, I don't want to have canola oil, and so if they think that's going to kill them faster than their cancer, then it's like fine, because everybody, who isn't using olive oil? So I like to know how my client identifies themselves. If they identify themselves as Paleo, this is really a real good place to start, because they've already eliminated the grains. They're kind of, they're still on the fence about the sugars, but we're making progress here. They know how to cook. They know something about food. They're not afraid of fat. They eat meat. We're good there. Mediterranean, people who identify with the Mediterranean diet. It's a little different for them. They have a hard time giving up that crusty bread because it's part of the allure of the diet. And sometimes they think it's, just adding a little bit of olive oil is going to do it. But, when I tell them they have to add a lot of olive oil and a lot of butter, it gets a little more challenging. But they really like to hear that they can have red wine back in after they're keto adapted. So Western diet, they're the hardest to get on board. And sometimes they come as a referral, and it is hard to get on board. But I have to tell you of one fellow that this worked for. I had to send him a picture of a steamer basket, a vegetable steamer basket, because he had never prepared vegetables in that way. And I thought, oh my God, this is never going to work. And we did the setup. I gave him a real simple template for meals, and he asked a few questions in the next week or two. And then a few months later, he got back to me and he said he just loved what he was doing. This was a great way to eat, and it was working for him, and he was getting some good feedback from his team. So, vegan. I hear from some people you can't do this as a vegan, and I know that's not true. It's a lot of work to do this as a vegan, but I have one really rewarding story I want to tell you of a woman who is now 3 years out on a glioblastoma. And if you don't know glioblastoma by now, she had a prognosis of 14 months, and that was with the standard of care. And the standard of care is a good resection and then radiation and chemotherapy followed by more chemotherapy. Well, she had the good resection, and she started the radiation and the chemotherapy, the Temodar. She developed an allergy to it about 3 weeks into it. And so she's not been on any chemo since, and her husband does, all the managing of the diet and figuring out the calculations, and it's been a real success story for her. So this is a huge problem here, and I just wanted to bring this up. Comfort foods they really get in the way of everything, and it starts right there with layers of love. We equate food with love, and we can't do that. And I just see now that I don't have a whole lot of time to talk about that, so just keep it in mind. And we'll go on to the next slide. And I love this. This is Black 6 over here, and if you feed him a high-fat diet, he gets very sick very quickly, and it's very efficient. But boy, when you look at the macros for his high-fat diet, which is 45% fat and a lot of sucrose, and you look at the layers of love brownie, there's not a whole lot of difference. So maybe they should just feed him brownies, and then he'll feel more loved and cared for. So I don't use diet ratio with adults. I go with macros as a percentage, and that's the basic range. There are exceptions, but I want to roll through the macros quickly here. So protein, I guess I don't have time really to talk about how I calculate this, but there are formulas for calculating it, and if the goal is nutritional ketosis, I go with kind of a mid-range of 1 to 1.2 grams per kilogram of body weight. If the goal is therapeutic, I drop it to the RDA, which is a little lower. And if people are coming with a lot of extra weight, then I go with lean body mass calculations. I go lighter on the protein for people who have brain tumors. I have found, my experience is that they do a lot better. Dairy and egg proteins can be a problem because they're insulinogenic, much more so than other proteins. And then I have a whole list of questions about protein that I would love to have the answers to, but that's for another day. Carbohydrates, 12 to 40 is a huge range. And of course, the most successful ketosis is going to be on the lower range, like 12 to 20. So if somebody is choosing all kind of low glycemic index, nuts or cruciferous vegetables, we can go towards the 20 in the induction part of it. But if they're going to pick, starchy or things like squash, or they're going to have sugary things like berries, we're going to keep it lower because of the impact. And that's one way to get around some of the issues we've been talking about. Fats and oils, I'm going to have to leave that, but I encourage a combination of fats and oils, and I'll just go through the things I tell people to take out, because I think that's the more important thing. I want them to take out trans fats. They're usually there. They're evil, and we can all agree on that. Soybean oil, corn oil, refined oils, and fat from industry-raised animals is a little iffy. So butter and cream, and high-fat dairy for women with estrogen-sensitive cancers. I'm very supportive of people choosing not to use those products because of the issues, the potential issues with the estrogen metabolites. Ketone supplementation, I have more questions than answers. So I think they're a great idea, but I don't know how to use them yet. I want to get to this accountability. People need to test in order to know whether or not they really are ketogenic. I need this data, they need this data. Because when they test and they see that there's sneaks and cheats have dropped their ketone levels. That's more important information, feedback directly to them than anything that I can say to them. So, circling back to accountability, I'll do anything to help somebody do this diet. But if it becomes clear that they're not on board with changes, then I put the ball back in their court where it belongs. Supplements, I'm not really going to talk about that at all. I think there's some things that need to be covered, because this diet being high fat, there is some nutrient issues. So before I go, I want you to meet my son, Rafi. And he lived his short life under the shadow of a brain tumor. And we learned about the diet, but it was years into the diagnosis. And I used to say, if I knew then what I know now, things might have been different, and that's true. But if I knew then what I'll know 10 years from now, that's the game changer. So moving forward, I would like all these things to happen. I would like there to be a certification process, and I want to thank these people. And Beth is here today, and she was an incredible amount of support to me in a very difficult time in our lives. So, thank you all.
We could accept 1 or 2 questions. We'll also have a 30-minute Q&A session with the speakers at the end of the next talk. So keep that in mind.
I just want to make one comment that you brought up about the steroids.
You can turn on the microphone on the comment.
Just pull it toward the switch for the front.
Perfect.
I just want to make one comment about a point that you brought up about the steroids. Unfortunately, oncologists think that dexamethasone or any kind of steroid is benign. And our group actually have demonstrated, it was published last year in British Journal of Cancer, that steroid actually interferes with chemotherapy's action against the tumor. So on one hand, we are trying to treat the tumor. On the other hand, we are trying to negate the chemotherapy side beneficial effect. Also, this is something that I tell my patient. Women with gestational diabetes, when their babies come out, they're bigger.
Yes.
Because of hyperinsulinemia, and steroid does that exactly. So patients, in my experience, when they are on steroids, they don't do as well as those who are aggressively weaned off their steroids.
Right, and thank you. It comes down to the medical team and whether the medical team is going to be supportive of trying something alternative like Boswellia. Yes.
Thank you so much for everything you've been doing for patients.
Well, thank you.
I also do oncology nutrition consulting, and I'm just wondering if you've ever come up against a side effect of the ketogenic diet of frequent urination. I have a client who, despite all rational approaches of electrolyte balance and all that, we just can't seem to manage it. I'm just wondering if you've encountered that and if you had any.
Sure, the diet has a diuretic effect, and so adding salted broth isn't helping. No, okay. What level of ketones? I'd be, if this was my client, I'd be looking at the level of ketones. The higher the level of ketones, the more diuresis you're going to have.
Not that high, 0.5, 0.6, so not very high.
Talk to me afterwards. We'll troubleshoot that one. Okay, thank you.